Welcome back to REBELCast. I'm your host, Salim Rezai. This is episode 122, Delayed versus Rapid Sequence Intubation in Agitated Trauma Patients. Now, we already know getting a definitive airway in critically ill trauma patients can be stressful. And the reason for that is the potential of a soiled airway, cervical spine injuries, maxillofacial injuries, head injuries combined with agitation, delirium, altered mental status, and hypoxemia, which can make securing a definitive airway both anatomically as well as physiologically difficult. Now, today we're going to talk about a new, hot off the press, randomized clinical trial comparing delayed sequence intubation versus rapid sequence intubation. And as always, I never do these things alone. We have the buttery smooth Swami who's making time for us as he's getting his house renovated. So Swami, welcome, and thanks for doing this with us today.
Absolutely. I've got half a house, so that's plenty to still get this done. And it's a great paper. It's a great topic to get into because I think we understand those challenges that you brought up. And the question then is, how do we safely intubate these patients? Because many of them need an airway. And the traditional approach is rapid sequence intubation, RSI. So we're going to pre-oxygenate, we're going to give an induction agent, a neuromuscular blocker, pretty close together, and then we're going to put the tube in. That's standard what we do. The problem with that approach is that some of these patients with trauma, because of agitation, because of delirium, they don't tolerate the pre-oxygenation period. And so you've got this potential really systemically injured patient who might be hypotensive, might be hypoxemic, and you're rushing in your RSI, which kind of sets you up for a bad outcome. What we would like then is to buy ourselves some time to pre-oxygenate, to do some resuscitation. And one way that we can do that is with delayed sequence intubation. And DSI is basically dissociating the patient with ketamine, doing the procedures that we need to do before intubation, then giving them a paralytic and intubating them. And the idea here is that using ketamine, the patient is going to continue to spontaneously breathe, and we can use that time to pre-oxygenate the patient. And that was really what this article was looking at. Can we use the ketamine to take away some of that agitation, allow the spontaneously breathing patient to let us pre-oxygenate them plus whatever else we're doing, and then intubate the patient when we have them physiologically prepared for that intubation?
And that's a nice segue into the paper. And I'm going to take the sword on this one, Swami, because good luck pronouncing that last name.
Bandiopadhyay. I got this one. No.
Okay, go ahead. Have at it.
I know. Bandiopadhyay. Peri-intubation hypoxia after delayed versus rapid sequence intubation in critically injured patients on arrival to trauma triage, randomized clinical trial in anesthesia and analgesia in 2023. Salim, I did spend a little bit of time practicing the name because I think that's important.
I agree.
As a person with a hard to pronounce last name.
What you don't know, Swami, is I have it phonetically spelled out on my document so that I could actually pronounce it correctly. I had prepared for this, but you stole my thunder. But that's okay. It's okay. It's okay.
I'll give you the next one.
So the clinical question these authors were trying to answer was, does delayed sequence intubation decrease peri-intubation hypoxia in trauma patients requiring definitive airway control compared to rapid sequence intubation? So Swami, we've alluded to a lot of this stuff, but let's just get into the nitty-gritty here. What did these authors exactly do?
This was a prospective randomized clinical trial. The patients were randomized either to get delayed sequence intubation, IV ketamine 1.5 mg per kg in 0.5 mg per kg increments until the patient was dissociated. They then got pre-oxygenated for 3 full minutes, then got a dose of succinylcholine and then intubation. Or they were randomized to get RSI, 3 minutes of pre-oxygenation followed by ketamine and succinylcholine and intubation. That's the traditional approach to rapid sequence. The characteristics for these patients, which were important to note, is that the intubations were all performed by second-year postgraduate anesthesia residents. the patients were pre-oxygenated via spontaneous tidal breathing for 3 minutes using a face mask with oxygen running at 10 liters per minute. Intubations were performed using direct laryngoscopy. We're not really going to be talking about DL versus VL. We've got plenty of posts on that, including the recent article by Driver and his colleagues. And the oxygen saturation was recorded at baseline and then every minute for the 3 minutes during pre-ox.
So the outcomes, primary was incidence of peri-intubation hypoxemia, which the authors defined as an SpO2 of less than 93% anytime from pre-oxygenation until 1 minute after intubation. And then the key secondary outcome was first attempt success rate, which was defined as any insertion of a laryngoscope beyond teeth, irrespective of intubation success. And then there was a series of other secondary outcomes, which we'll list in the show notes. Now, Swami, when we talk about inclusion, we've already said adult trauma patients presenting to a trauma facility requiring definitive airway. Was there any important exclusions that we need the listeners to know about?
There actually were. If the airway was anticipated to be difficult, then they excluded the patient. So this was defined as difficult mask ventilation, difficult laryngoscopy, difficult tracheal intubation. They also excluded patients that had extensive burns, active vomiting, the crash intubations, and cardiac arrest. That limits a little bit of the generalizability because we would like to see this across all patients, but I get it as well in the patients who have these kind of factors, especially the burn patient where you think this is a dynamic anatomic airway. You don't even want to wait 3 minutes because that little bit of time might take the airway from difficult to impossible.
100%. And when we talk about how did they get to the number they got to in terms of what they included in this study? So they looked at 13,500 trauma patients. Of those patients, 1,000 needed to be intubated. 542 of them were intubated as out of hospital intubation, so they were excluded. Another 245 were excluded for meeting just their exclusion criteria, which Swami just went over, which left 236 patients to be randomized. Now, another 36 patients got excluded due to unanticipated difficult airways, which left us with 200 critical patients, 100 in each group, requiring definitive airway management. Now, the demographics of note, Swami. Most patients' reason for intubation was altered mental status due to polytrauma with associated head injury. As a matter of fact, the median GCS in both groups was 6. Motor vehicle accidents were the most common cause of trauma, so blunt trauma in 82% of patients. Now, Swami, let's get to the critical results. That primary outcome of peri-intubation hypoxia, and then that key secondary outcome of first attempt success.
So what they found was that in the DSI group, peri-intubation hypoxemia was found in about 8%. In the RSI group, it was 35%. That's a 4-fold difference, and that was statistically significant. For first attempt success, the DSI group was 83%. The RSI group was 69%. That was also statistically significant. And I think that what we see here is that if you avoid that peri-intubation hypoxia, you can take more time for that first attempt, which is going to give you a higher rate of success. That's how those two things are tied together. The overall first attempt success rate, a little bit lower than I think we'd like to see, but nonetheless, these are the numbers that we have, and we see some pretty significant differences here.
Yeah, and so getting into strengths and limitations. So this is the first randomized clinical trial on DSI versus RSI, right? We've had an observational study that I think I've reviewed before on REBEL-EM. I'll have to double check that. If not, it might be something we need to add to this post. But this is the first RCT looking at these two. It asks a clinically important question because it's been based on expert opinion on a lot of these things, whether we should be doing DSI versus RSI. And I think the authors did a great job clearly defining what they meant by delayed sequence intubation, rapid sequence intubation, peri-intubation hypoxia, and first pass success.
There's some important limitations, I think, too, Salim, for us to get into. I think we can start with the primary outcome here. The primary outcome is the oxygen saturation less than 93%. That is a monitor-centered outcome. It's not patient-centered. The patient doesn't care that their sat was 92% or 91%. So that is a little bit less relevant. I actually would have liked to see the first pass success as their primary outcome. That would have been a little bit better, a little bit closer to a true patient-centered outcome. But this is what they did, and we're just kind of pointing that out. So that's something that I think we would have liked to seen differently. there's a little bit of a problem here with generalizability when you look at the large number of intubations, take out the pre-hospital ones because there's nothing they could have done about that. You're still left with about 450 possible patients to be included for the study. And then more than half of those was excluded due to their criteria. And so you really have to hone this down and say, this is not something that I can apply to all trauma patients. We're really selecting a group here. It's a significant group, but still we are selecting a specific group to apply this approach to.
Yeah, I couldn't agree more. The other thing I would add here as a limitation is that no knock against the anesthesiology residents, but we're talking about people who are in training, so still learning how to do intubations. And so what you said earlier was if we're tying together first pass success and hypoxemia, well, if you had more experienced people doing the intubations, would we close that gap a little bit of that difference in severe hypoxemia just simply because more experienced people will get the airway faster? And so we can't answer that question because this was clearly, it is what it is in terms of what was included. And so I would list that as a limitation as well, Swami.
Absolutely. I think these are important things for us to consider, but at the same time, those strengths are really important. The ones that you pointed out, we have been talking about DSI and RSI. Now we actually have some data to drive us forward to determine whether this is something that we should be applying. And I think, Celine, that brings us into our discussion because there are some really important points here in terms of clinically applying this data.
Yeah. So, when we talk about trauma patients with agitation and delirium, they tend not to cooperate with face mask application for pre-oxygenation. And the big issue is reoxygenation with bag valve mask. And that can increase airway-related adverse events like things such as aspiration. And therefore, adequate pre-oxygenation is crucial to decrease the incidence of peri-intubation hypoxemia, which DSI actually showed in this trial.
Yeah, that is pretty cool. And I think the other thing is for the listeners who maybe aren't as familiar with all of these ideas, I think one of the important things is looking at those outcomes. Obviously, what we would love to see is we did this approach and we saved lives. But that's a hard jump to make without a much larger sample size. And so we look at things like first pass success and pre-oxygenation. First attempt success has been shown in other studies to affect mortality and morbidity. And so we're kind of extrapolating and saying first attempt success is always a good thing for us to look at in terms of airway management types of articles. And again, that was their secondary outcome. I think you and I both would have liked to have that as the primary outcome. But nonetheless, hypoxemia also important. And I think all of us would agree that we would like to adequately pre-oxygenate the patient before we attempt the intubation. And so getting that sat into that 98, 99, 90, 100 range is really important prior to intubation because it buys us more time for our attempt.
Yeah, and so tying those two together, pre-oxygenation and first attempt success, which is not what this study did. So I'm kind of doing a little bit of reading between the lines. Of the 17 patients who could not be intubated on first attempt in the DSI group, 8 were due to desaturation, which required a bag valve mask. That's 47%. Of the 35 patients who could not be intubated on first attempt in RSI, 31 were due to desaturation, which required bag valve mask. That's 88.6%, Swami. So it was twice as many were desatting and could not be intubated for that first attempt success because of that desat in RSI compared to DSI.
So I think taking all of that together, we have to say, really, how do we use this going forward? Understanding that it's not perfect. It's not the perfect study. It's not as large as we'd like it to be. It doesn't have that great, perfect patient-centered outcome. But I do think that this is a reasonable data set for us to use to advise our clinical practice. And I think the author's conclusion here is actually fairly good. DSI appears promising in critically injured trauma patients who do not allow adequate pre-oxygenation due to agitation and delirium and require definitive airway on arrival. I think that's a pretty measured author's conclusion. Appears promising. And I think when you see those words, at least when I see those words, Salim, what I say is that the authors are acknowledging that they've done a study, they've shown us something, but they would really like to see some further data. And this should really be the impetus for other groups to say, okay, now we have something to start with. We have a true signal for for benefit here. So let's go and get some more data.
100%. And I think our clinical take-home point is in altered, agitated trauma patients not tolerating pre-oxygenation who need definitive airway control, DSI reduces the incidence of peri-intubation hypoxemia compared to RSI and should be considered as the go-to strategy for intubation until we get better data that states otherwise.
Salim, let's take this a little bit out of the paper just for a moment, because I do think this is important. This was all in trauma patients. Most of the patients that I intubate are not trauma patients, and I think most of the patients you intubate are not trauma patients. I think this is one of the big questions is, can we take this out of that group and generalize that to the other groups of patients that we see? Or I guess the question is, are we already doing that? And there's no real point. And so I think that that is an important step. I already use this in my critically ill medical patients who need intubation and are hypoxemic or are agitated because they're so hypotensive or because they're so hypoxemic or because they're hypercarbic. I use this approach pretty frequently to make sure that I can pre-oxygenate the patient, I can adequately resuscitate the patient, and then get them to a nice place for me to intubate. Sometimes it's more than 3 minutes though. In fact, it's often more than 3 minutes that I'm taking to do all of that. So I do think we are carrying this outside of this group. Again, we would like to see some data in that particular group telling us that it's the right thing to do, but I think a lot of us are already doing it.
Yeah, I'm in the same boat as you. I'm already doing it. So, if I can't get the patient pre-oxygenated, they're getting a little bit of sedative until I feel like they're sedated enough that I can get them pre-oxygenated. The other thing I'd add here, Swami, that is also kind of like a DSI is sometimes critically ill patients can have more than one thing wrong with them. Sometimes they can be hypoxic, they can be agitated, and they can be hypotensive. And so sometimes I'm giving just a small dose of ketamine just so I can get them sedated enough to oxygenate them and to get my vasopressors up so I can get them hemodynamically stable. So I'm using that period of time as a sort of DSI before I'm pushing the rest of my sedative or my paralytic. And so, yeah, I'm definitely doing this outside of just trauma patients.
Yeah, it's that time to resuscitate before you intubate. Saying resuscitate before you intubate is well and good, but sometimes the patient doesn't make it easy to do that. I had a patient recently who was markedly hypoxemic, markedly hypotensive and tachycardic, and very altered and pulling at everything. And so we needed to do some type of sedation in order to resuscitate the patient prior to taking that airway. One of the problems, Salim, that we're running into, and this is going to date the podcast if someone listens to this in a couple of years, but for right now, one of the things we're running into is ketamine shortages, and that makes this a little bit difficult to get it done. While these are all suboptimal, I have used other medication approaches to making this happen. I've mixed some haloperidol with tiny amounts of midazolam. I don't like to do that, but I also saw that I really didn't have much of a choice. I have used etomidate, but again, this is not a place where I really like to do that. I would rather have ketamine, but again, acknowledging the limitations that are in front of us, sometimes you got to do what you got to do, and it's really not safe to intubate a patient who is hypoxemic and tachycardic and hypotensive without getting some time for resuscitation.
Yeah, and so that's kind of where I'm using it. And I know that's not what this study was about, but I'm doing this in everyday practice. I may not call it DSI, but let's face it, that's exactly what I'm doing. That's exactly what I'm doing, right? So now we have, I think a lot of us are doing this, but now we can say, okay, not the greatest randomized clinical trial in the world, but there is a randomized clinical trial that does show us some signal of benefit here. So it's not just something that two cowboys are doing in the ED. It's just like we do have evidence now to kind of support that practice of what we're already doing, whether we call it DSI or resuscitate before you intubate. That's what it is.
Yeah, and while the data here isn't ideal, it may be as ideal as is possible for the problem, the clinical problem that we're looking at. It's very difficult to do the highest level of randomized control trial in this sort of a patient group. I think that these authors did a fantastic job getting us some really good data, while not perfect. And of course, perfect is the enemy of good. Sometimes you got to publish good data because getting perfect data is virtually impossible.
And there you have it, Rebel EM listeners. Thank you for tuning in. Please leave us your thoughts, comments, and questions. And until next time.